Thank you so much for joining us on this sunny Monday evening. We are so happy to have you with us. I know there are lots of questions all across our community about how the vaccine rollout is going, both in Virginia and right here in the Blue Ridge. And we are very fortunate tonight to have some of the leading experts on that topic with us. We're going to make sure that we get all of your questions answered if you are joining us. Real quick, just a little bit of orientation. There are two places to watch us tonight. We've got YouTube and we've got Facebook, and there are comment sections in both. And so if you have a question that you would like answered, please drop it in there. We will make sure that we get to as many questions as possible tonight. We have four more distinguished panelists with us, including many who are really top-notch in their field when it comes to understanding how the vaccines are going. With us tonight is Dr. Danny Avula. He serves as Virginia's statewide vaccine coordinator. He was appointed by Governor Northam this January. Before that, he was director of the Richmond City and the Henrico County Health Departments and practiced clinically as a pediatric hospitalist. Dr. Avula is also a UVA alum. He attended VCU School of Medicine and completed residencies at VCU and Johns Hopkins, where he also received a master's of public health. Dr. Avula, thank you so much for being with us this evening.
Happy to be here, Sally. Yeah, thank you.
Thank you. Also, from right here in the Blue Ridge, we have Mr. Ryan McKay. Ryan is the Director of Policy and Planning and the Incident Commander for COVID-19 operations for the Blue Ridge Health District. He served our district for 7 years, 6 years before that in the New York City Department of Public Health, and also happened to teach high school here in the Central Virginia region, so has worn a lot of hats over the years. He did his master's in public administration at JMU. Ryan, thank you for joining us as well.
Thank you for having me.
And we also have with us Dr. Tyson Bell, who directs the medical ICU at the University of Virginia Hospital, where he's an assistant professor in the Division of Infectious Disease and International Health and Pulmonary and Critical Care Medicine. Over the past year, he has led UVA's COVID care units and has developed quite a reputation for his weekly webinars of his own. So I know he's a familiar face for many of you. Dr. Bell's also a UVA alum. He completed medical school at Columbia University and trained in internal medicine at the Massachusetts General Hospital, where he was chief resident. Dr. Bell, thank you for being with us.
Thank you for having me.
Thank you so much. And of course, we also have Senator Creed Deeds here with us. Sir, how are you this evening?
Good to see you, Sally. I learned a lot last week in Charlottesville, and I know this will be great discussion.
So Senator Deeds and I tonight are just the MCs. It's our job to take in all of the wonderful questions that you are bringing our way and then tee them up to our expert panel here. And we will not waste any time getting to it. We've got a lot of ground to cover. We want to know how the vaccine is getting rolled out across Virginia, how we're doing in particular here in the Blue Ridge. We know there are lots of options, lots of different ways to get it, whether it's in the Blue Ridge Health Clinic in the J.C. Penney, or whether through one of our pharmacies or the FEMA centers. We know there are lots of different shots options, lots of different people who need them, and lots of questions from you. So we're going to cover a lot of ground. Just to start things off, Dr. Avula, our first question is for you. Can you just orient us to how the rollout is going across Virginia right now, maybe with some top line metrics? How many shots, how many people have had their shots? How many shots are we getting out a week? How are things going from your perspective?
Yeah, well, it definitely is gaining momentum, and as we would hope, each week looks better than the week before. As of today, we have 4.2 million total doses administered, and over 18% of our population is fully vaccinated. So about 33% who have at least one dose, and that fully vaccinated number keeps going up the more and more Johnson & Johnson we get, because we get full vaccination with one dose. And so that's been a real boost to the effort. You may remember at the beginning of this whole effort, we wanted our initial goal was 25,000 doses a day. We knew we would eventually have to get to 50,000 doses a day to be able to get Virginia vaccinated by the summer. And we are significantly outpacing that, in large part thanks to the federal government for mobilizing more and more vaccine each week, and really an amazing part to the health departments, health systems, and so many other providers who have just turned out in droves to be willing to deliver vaccines. So this past week was pretty remarkable. We had 2 days where we had over 100,000 doses in a single day, and we are currently averaging about 78,000 doses delivered a day. So really making great progress, and I think we're going to get to some of our goals to vaccinate at least everybody who wants to be vaccinated by probably about the middle of May. And so that's good news in many regards, because it means that people are going to get access to vaccine as they want it much sooner than we originally expected. I think the news that needs work is that really only gets us to about 60% of the population. And if we want to get to our goal of 75% herd immunity, it's going to take a different kind of work. It's going to take getting out and doing community-based vaccinations in neighborhoods. It's going to take the hard relational work with, key leaders and key networks on the ground. It's going to be sort of the non-judgmental conversations with people who have been really vaccine resistant. And so, I think we're still shooting for that 75%. It may take us the rest of the summer to get there, but for those who want it, it's coming soon.
Wonderful. Thank you so much.
Dr. Bell. Dr. Bell, there's several different options for vaccines: Pfizer, Moderna, Johnson & Johnson. There may be others. Are there considerations for patients who might try choosing between the three of them, or the multiple vaccines that are available? There are also different providers for the vaccine: the health districts, the FEMA centers, the federal pharmacy program. Can you outline those options for us, and what considerations people ought to be taken into account?
Sure. So I'll give an overview of the vaccines that are authorized right now, and I'll kick the second part of that question to Dr. Avula for the different options. So just to review, there are 3 different vaccines that are authorized right now. 2 are Pfizer and Moderna. These are messenger RNA vaccines, and they work by inserting a piece of genetic material that serves as a recipe for your cells to make a spike protein that's a part of the SARS-CoV-2 virus, not actual COVID-19 itself. It teaches your body to make it. Your immune system makes a response to it. And then your immune system learns how to deal with it if it comes back and really jump the gun so that you don't get sick. Those 2 are the first ones that were authorized, and we have a little more familiarity with those. The Johnson & Johnson is slightly different. It works with a cold virus they've made harmless, so it doesn't cause you to get sick, and it uses DNA instead of RNA. But you're getting to the same destination. You're making that spike protein by itself without any other part of the coronavirus. Teaching your immune system to make the spike protein and then to make that immune response. And then later, if you do come in contact with the virus, you don't get sick. So those are the 3 that are available. As far as the differences, I think the first thing to say is that the first one that's available to me is the one that I would get at this point. I think all 3 have been shown to be very safe and very effective. If there's no choice and there's one that's available, that's the one that I would get. And that's what I would do for my family. And that's what I've advised my own family to do. Differences between them: Pfizer and Moderna, they're basically the same sort of mechanism. They work the same way. They're both 2-dose shots. So that's one difference between these and a Johnson & Johnson. Johnson & Johnson is 1 dose. The Pfizer and Moderna are both 2 doses. So that's one consideration. The Johnson & Johnson is also a little easier to store. And I'm sure that's one of the reasons Dr. Avula is excited about it, because it is a little easier to distribute. It's also simpler because it's that 1 dose as well. But the bottom line, there are some differences in that what's called that top line efficacy: 94 to 95% for Pfizer and Moderna versus 72% for Johnson & Johnson. And that can be a little misleading because it gives the impression that the Pfizer and Moderna are that much more better than a Johnson & Johnson. But I think the thing to remember, at the end of the day, what we want to prevent are people getting sick from COVID-19, going to the hospital and dying from COVID-19. And if you look at how well they perform against each other, they all provide basically 100% protection against people getting so sick from COVID-19 that they go to the hospital or dying from COVID-19. And that's why I say the one that's available to you, that's the one that you go get.
Thank you so much, Dr. Bell. So those are our different options when it comes to brands of shots. And Dr. Avula, we would also love to have you talk to us about the different places where you can get your shots, because we know that there are some options there as well. We've got pharmacy programs and FEMA centers, and we've got health districts and community clinics. Can you talk to us about the different options for delivery there?
Yeah, well, what we're doing right now at the state level is trying to, make sure that every community has access to as much vaccine as possible. We are doling out Moderna, Pfizer, and Johnson and Johnson. Really, as soon as it's coming in, Virginia is among the leaders in the nation in terms of our efficiency to get vaccine out as quickly as it comes in. And what we generally do is we work off of the base allocation of Moderna and Pfizer that goes out to localities. The numbers for Johnson and Johnson come a little bit later, and our week to week variation on the Johnson and Johnson vaccine has been really it hasn't been consistent. And so we started rolling it out with anybody who's ready to do mass vaccination events. But then we recognized, to Dr. Bell's earlier point, there's a lot of great benefits of it not, being one dose, not having to be frozen, the usefulness in certain communities like hospitalized patients where it's difficult to coordinate that second dose administration. College students coming up, we really want to get college students vaccinated before they go home. And to be able to do that with one dose instead of having to coordinate a second dose once they've traversed the country is going to be really beneficial. So right now, we basically try to do a demand-based allocation. We want to make sure that every district can get to phase 2, and we can talk more about that later. But by April 18th, and so we're really shifting allocation, shifting vaccine to the communities that have greater demand, and then the health districts are largely deciding how much of that is going to go to a health system partner, how much of it is going to be channeled through pharmacies, and how much is the health department or other private providers, medical groups, and then how much is the health department going to actually deliver itself. So that looks different in every district. And there's one other huge piece of this, which is the federal retail pharmacy program. They get all 3 types, Moderna, Pfizer, and Johnson and Johnson. And that comes as a direct allocation from the federal government and is being pushed through pharmacy chains all over the state just to increase the access points for as much vaccine as possible.
And that's a big hunk of the supply at this point, right?
Yeah, it's about 1/3 of our total doses. And really the President Biden announced maybe last week, maybe it was the week before, but that they wanted every American to be 90% of Americans to be within 5 miles of a vaccination outlet. And so they've really heavily relied on pharmacies because they have such widespread footprints. So yeah, about 1/3 of our total doses going through the retail pharmacy program.
Dr. Avula, and there was recently reported that a lot of people from Charlottesville were going to Danville and different places. Have you changed the allotment to the health districts in response to this, or how exactly are the vaccines distributed among the health districts?
Yeah, we have done a lot of changing almost every week, Senator. It's sort of a different approach. We started back at the beginning in December. Most of the vaccine went to hospitals and health systems because they had the healthcare providers. And so that's where the initial flood of vaccine went for the first 2 to 3 weeks. In large part, that was due to their ability to do the cold storage, the ultra cold storage around Pfizer. That shifted over the month of January to health departments, largely on a per capita calculation. Trying to shift as much vaccine, as the population of each community would demand. And then we would tweak that each week. Some weeks we recognized there were lower vaccination rates in some communities. And so we would push more that direction. And then we would, as we wore on in the process, we recognized that there were certain segments of our state that you really just saw less demand. And so over the last 2 weeks, as we've seen demand wane in some communities, we shifted it to communities where we've seen much more demand. And that's where we are now. If you look at the skew, you'll see districts like Fairfax, a bunch of the Northern Virginia localities, certainly the Blue Ridge Health District, the Peninsula Health District, that are getting much more than what would be their per capita fair share, just because they have more demand and more uptake.
And Ryan, can you talk to us about that a little bit? What are some of the factors from your perspective that might be driving high demand where we live? And what does that mean right now for who's currently queued up to get their shots in our area?
I think one of the things that's put a tremendous demand on us as a health district to provide vaccine is just the nature of who makes up our 1A and 1Bs. So we have a pretty large 1A population of healthcare providers. Given that there are two health systems in Charlottesville, there comes with that a lot of independent offices. We have a tremendous amount of dentists, individuals who are actually eligible in 1A. And then we also have a pretty large segment of the 1B population that makes up our overall population. Charlottesville and the surrounding communities. It's a magnet for retirement communities, individuals who have moved here. And so our population of 65 and above makes up a pretty big portion of what our overall population is. So it's taken us a little bit longer to get through the 1As and the 1Bs than in comparison to some other health districts, particularly the more rural health districts who moved on to 1B or 1C before we did. So that certainly increased demand. I think the other is that our allocations based on what the federal government was providing Virginia, our allocations for 4 weeks was a lot smaller than what we would have wanted. And so trying to divide those allocations up between our locations where we were dispensing, whether it was in Charlottesville or the localities, and what UVA Health was doing out of Seminole Square, plus our community events, it took that small allocation and every slice of the pie from there had to be pretty small as we were trying to really provide equitable access across the district. And so demand grew for a resource that just wasn't widely available. And I think when we moved to 1B, we also understood that the allocations didn't necessarily meet the demand for 1A and 1B. So about half our population became eligible when we moved to 1B. And so while we were trying to provide wider access, just the availability of vaccine from the federal level down to the state and local level didn't necessarily meet with that demand.
And are you feeling better about how that's going? I saw a big flood of appointments get posted this week.
Yes, we feel a lot better. So I will say we've been persistent and are asking for more vaccine, and we've seen a really steady increase. And this week we've gotten our biggest allotment between what the health district is getting and what we're providing to some of our partner pharmacies and primary care providers. In addition, UVA Health has seen more, I think, this week than they have in previous weeks. And so we've gotten a huge uptick in vaccine, and we're really excited that we're able to provide those opportunities as our population that's eligible has grown. We are currently up to 1C right now.
Dr. Bell, we're getting more evidence each week about vaccine efficacy for important subgroups of patients. Can you talk a little bit about what we're learning about the vaccines for pregnant and nursing mothers? And maybe can you talk about vaccines in younger patients and what that means for school reopening?
Sure. And I'm really excited to share this news because as many of you know, pregnant women were not included in some of these phase 3 trials, or any of them really. And that's been a point of frustration. And what we've been telling women of childbearing age is that these look safe, they look effective. Overall, it's a good idea to get the vaccine, talk to your physician. But now we actually have data that actually proves that it is safe, it is effective, and there are benefits for the baby. So there's a study that recently came out from Brigham and Women's Hospital in Boston. I'm partial to Brigham and Women because I was born there. But they were looking at women of childbearing age, 131 total women, 84 of them were pregnant at the time, 31 were breastfeeding, and then there were 16 that were non-pregnant women, age 18 to 45, and they were kind of like the comparison group. So what they found were 3 major things. So the level of antibodies were produced by each different group were about the same, so very good. The antibody levels were actually higher in the women who were vaccinated than in women who had been naturally infected with COVID-19. So a good argument to even consider vaccination if you've been infected with COVID-19 and get those antibody levels higher. Side effects were mild. It was generally well tolerated. And then antibodies, the greatest news here is that antibodies were found in the umbilical cord blood and in breast milk. So what that means is that babies, unborn babies and babies that are breastfeeding get a measure of protective immunity through these antibodies that the mother produces. This is very similar to what we see with the influenza vaccine. When women get the influenza vaccines, they pass on some of those antibodies to the baby, which is a big deal because Dr. Avula, this is clearly your lane, so I'm stepping lightly here, but babies, when they're born, their immune systems are incomplete. They don't function at tip top. They're still learning and still building and generating those cells. And so to be able to provide that immunity through those antibodies that mom has produced, that's a good level of protection to give the baby. So that's the first. And then as far as children themselves, there's recently data released by Pfizer in a group of children aged 12 to 15. And this trial showed that there was 100% efficacy. So none of the children who received the vaccine actually had COVID-19, and they had robust antibody responses. Actually, in this study group, they generated the highest level of antibodies of anyone studied in the trial. So of all adults, of everyone else, 12 to 15-year-olds generated that highest response. Again, it was very safe, well tolerated, works very well. And then Pfizer is also doing a trial in children aged 6 months to 11 years. That is going to be reported on soon, but because of the good results from what we've seen before, they're looking really at dose levels and safety, assuming that it will be very efficacious, meaning it'll work very well. So very exciting news that supports the use of vaccination in pregnant women, lactating women, any woman of childbearing age, and in children.
Maybe I can connect this to the question that we got from someone in the chat. Becca is wondering what that means for when the vaccine might be available to adolescents here in Virginia. I know that we have a goal, Dr. Avula, of starting to vaccinate everyone age 16 and up, starting in the middle of April. Do we have any prognosis for when we might start rolling things out to those middle-aged teenagers?
Well, we had been targeting October, but the Pfizer data looks so good and kind of came unexpectedly soon. So I think as they wrap up that trial and submit data to the FDA, I think their goal will be to have a vaccine that's ready to go prior to the school year, at least for the 12 to 15 population, to cover that gap. It's going to be a little bit longer on the younger age groups. I mean, I think we're anticipating the spring of 2022 before we have an approved vaccine for younger children. But yeah, I think it is possible that we could have a vaccine ready to go by late August, early September.
I'm sorry, I had to unmute. I've read that the vaccine is, we still don't know how long it's going to be effective, that we might need boosters, and the variants of the virus suggest that we may need boosters down the road. What's the latest on all of that?
Well, I do have some news there. So Pfizer recently released a 6-month follow-up from their phase 3 study. So the phase 3 was the original trial that they used to submit to the FDA to get that authorization, but they continued to follow those patients over time, about 44,000. So now at the 6-month mark, they continued to track cases and found that at the 6-month mark that the level of protection was still very good, 90%, 91%, somewhere around those levels, very effective. And importantly, this was during the era when we started to see more of these variants. And they actually had a group of the trial that was enrolled in South Africa, where the so-called South Africa variant, which is the one that has shown that potential to lower the level of antibodies, or the vaccines do still seem to work, it still offer protection against that. So that's good evidence that the vaccines do induce a good immune response that lasts at least a duration of several months. The question of, are we going to need a booster at some point? We're just not sure, and I don't want to make up an answer, but it depends on a few things. It depends on how long and how high those antibody levels persist. They do tend to go down over time. There are other sorts of immune cells that are involved in your immune response, so it's not just antibodies. And then the story of the variants, which is really the one of the main concerns right now with public health experts and physicians and people that are tracking this. We haven't seen evidence of a variant now that has been able to so-called escape the vaccine, but that possibility does exist. And so down the line, will there need to be a need to update the vaccine? The vaccine companies are already looking at that possibility. It's not clear if we'll need it right now, but that might be one of those variables that we may have to just see how things go. But very good news that at least for a duration of several months, and I expect it will last longer than that, you do seem to have a good level of protection.
So it sounds like good news keeps coming from the scientific research about the efficacy of these vaccines and about different groups of patients that they're serving well. And a lot of the open questions from folks are about whether we'll have enough vaccine to continue to hit these markers and goals for the rollout. We had a good question here from Connor in the chat. Maybe Ryan, this would be a good one from you. given this uptick that we have in the supply of vaccine to the Blue Ridge, do you think that we're going to be able to make that April 18th deadline of moving to phase 2?
Yes, so we've been looking at where we are with our appointments, looking at our allocation and making some estimates about where we are in terms of getting through the 1A through 1C, particularly just in terms of providing appointments. And so we want to actually move to phase 2 beginning a week from today, where we would be providing individuals with the opportunity to, at the very least, schedule appointments. So that would be everyone 16 and above. And then hopefully scheduling an actual appointment sometime in May. So the uptick has been great. We think that there's a lot more people out there that obviously want it, but we feel like we're in a good position based on the allocation that we received this week, what we would anticipate minimums being over the next several weeks to move into phase 2 a week from today.
That's great news. I get to see you tomorrow for my first Pfizer.
Excellent.
So we have other questions here now about what all of this means for public health restrictions, because as we see more and more people get vaccinated, we've got lots of people who are eager to be out and about. Maybe just to start, by way of summary, Dr. Avula, can you tell us what the current state of health restrictions is in Virginia when it comes to gatherings and businesses? What's currently safe for folks to do?
Yeah, well, maybe the good news is the trend, both in, how the CDC assesses the data that keeps coming out, the really reassuring data around just how effective vaccination is, that translates to new CDC guidelines on basically, every week. And, the most recent one being new travel guidelines. People who are fully vaccinated, should still be careful, but are good to go in terms of domestic travel. Don't need to quarantine, not that they did before, although it was certainly advised. But, I think there's just a level of assurance that we're seeing based on just how effective vaccination is. Other things around being fully vaccinated, and then I'll get more to your specific question. But, if you are fully vaccinated, which we consider 2 weeks after your final dose, you can spend time with other people who have been fully vaccinated indoors without wearing masks. That's a huge change for so many of us. And if you are, let's say you're fully vaccinated, but you want to spend time with people who are unvaccinated, let's say you're a grandparent, you've got your vaccine, but your grandkids don't because they can't yet. The CDC guidance is that you can spend time in their home with one other family without wearing masks and distancing. And so that has been a game changer for so many folks who've been waiting so long to kind of reconnect with family. I think when we get to situations where you've got multiple family units and you're starting to mix up the risk, we really do continue to recommend masking and distancing. And that has led to a recent change for the way that we consider social gatherings, where it used to be groups of 10, that is now groups of 50 indoors and groups of 100 outdoors. And so that is a significant loosening of the mitigation guidelines, but still want folks to be careful, want folks to wear masks and socially distance. And I think, when you look at what's happening around the country, you see over the last 2 weeks, we've had about a 15 to 20% increase in COVID cases. And in some parts of the country, that's been accompanied by an increase in hospitalizations. And so, there's a part of me that we're going to see these bumps, these spikes, as particularly younger people start to gather. The weather's getting nice, and everyone's tired of doing mitigation. But at some point, we'll have enough of the population vaccinated where the severe consequences of COVID that we're concerned about will really be protected against. But we're not there yet, at least as evidenced by hospitalization rates in some communities. And so still a full court press to try to get as many people vaccinated as quickly as possible, followed by an adherence to the mitigation strategies until we can kind of reach that breaking point.
So it sounds like folks who are fully vaccinated can really be going back to life almost as normal, but that the rest of us need to be continuing on with a lot of those really strong protocols.
I wouldn't quite say it that way. I mean, I think when you are fully vaccinated and you are out in public and with, multiple other individuals, we are still asking folks to wear masks and do the social distancing. But it does, I think there is enough very compelling evidence that full vaccination does allow you to do some of these previously risky things, because vaccination really does work that well.
what is the science with respect to children who are becoming sick? I mean, because from what this sounds like, we won't have any protocol until next spring for young children. Shouldn't we still be wearing masks probably until next spring until we get everybody vaccinated?
Well, COVID has not really been a significant illness for young children. The vast majority of kids who get COVID either have asymptomatic disease, we estimate about 40%, so no symptoms at all, or they have very, very mild symptoms. And I think that, when we think about things like in-person school as one example. One, we've seen plenty of data thus far in school systems that have gone back in person, that have executed the mitigation strategy. So they've enforced mask wearing, they've enforced distancing, they've done a really good job of screening students for symptoms and keeping them out of the classroom, that we're not seeing significant spread in those settings. So as it relates to in-person school, I think the data is really good to show that schools who can commit to these basic mitigation practices can absolutely control the spread of COVID. And any spread that typically does happen is much more likely to be teachers and other adult staff that are either contracting COVID outside the school or in teacher-to-teacher interactions, not teacher-to-student interactions. But then even more broadly, when we just think about community transmission, I think kids aren't really going to get severe COVID disease. So I could very much see a point where, we have 75% of our adult population vaccinated. We no longer are seeing that many adult cases, and we may still see some transmission among kids, but it's really not going to be that much of a concern because they just get very mild disease.
On that point, we had another good question in the chat from Mary Margaret about what the future looks like for adults who are vaccinated but have friends who are still very vaccine hesitant. It sounds like you said if you are, say, a grandparent who has been vaccinated, then it might be safe to spend some time with an unvaccinated grandchild. But if you've got older people who have some friends who are currently choosing not to get vaccinated, what does the timeline look like for that?
When you say for that, the ability to connect with those unvaccinated individuals without wearing masks,
or what are the months going forward if we do have, as you said right now, at the beginning, you said it looks like maybe only 60% or so of Virginians currently sound like they want to get the vaccine when it's available to them. If we struggle with that last 40%, what do the months going forward look like between people who are and are not vaccinated?
Yeah, so in terms of timeline, I think that's right. I think by the end of May, we'll get to about the 60% of the population, the low-hanging fruit, the folks who want to get vaccinated, have signed up and are just waiting for the vaccine to be available. I think the rest of the summer, June, July in particular, will be that really hard work to get to that last 10 to 15%. And it's going to be, you'll see a shift of the strategy to go out in mass vaccination, getting as many people vaccinated as quickly as possible, to much more of the vaccine going to private providers on the ground, right? People trust their doctors and nurses. That's who they go to for advice. And so the importance of that provider relationship to get vaccine hesitant folks who are on the fence, to get them to get vaccinated, that is going to be a really big part of the strategy, as we progress through the summer. I think many health departments and other providers are also really trying other strategies. They're doing mobile clinics in trailer park communities, or they're going into public housing neighborhoods, or we've got to continue to try ways to lower barriers. Think about our non-English speaking and undocumented populations. They're not going to sign up in a state database. They're not going to show up to a mass vaccination where law enforcement is directing traffic. So there are a lot of things that we've got to do to increase uptake in some of these segments of our community. But we also know that some of our greatest vaccine hesitance is in the sort of rural Virginia and folks who lean more conservatively politically. You know, the national survey data is pretty clear that the politicization of everything COVID is bearing out in vaccination as well. And so I think that, you know, my hope is that we get to 75% through these very particular strategies with these segments of the community over the course of the summer. And if vaccination gets to a point and we see the COVID cases drop to a point, and I think that other point I mentioned earlier, that COVID hospitalization and COVID deaths stay low, right? Like those are the outcomes we care most about. We've already seen a remarkable decrease in the long-term care facility and nursing homes and assisted living in terms of COVID cases and COVID deaths. And so I think if we see that pattern persist, a lot of the mitigation restrictions will start to be lifted into the fall. But that, you know, there's a lot of ifs around that, but I think that's what we can hope in terms of a best case scenario.
I think you identified a lot of good practical barriers to some people getting vaccinated. I wonder, perhaps Dr. Bell, do we also have any good research on messaging when we think about messages that are resonating with people who are vaccine hesitant? Are we learning anything about what the most effective tacts are?
I think one of the most effective tactic is to first find the underlying reason why someone may express hesitancy or an unwillingness to get vaccinated. A lot of times when we're talking to community members, we'll hear the concerns, but there's usually some underlying issue there. So whether it's trust in the process, the federal government itself, given the prior administration was not particularly trustworthy, or a pure information gap. You know, how do the vaccines work? Will it get to my DNA? Will it alter me? The answer to that is no. And then some people just want to see someone that they trust and know who's either gotten the vaccine or talked to them about the vaccine. So we found a lot of traction when we've spoken with community leaders, faith-based leaders, organizations that are already in the community, providing services, providing help to people. There are natural leaders in communities, which if this one person gets vaccinated and everyone sees it, there's going to be a lot of people that follow. But what we're seeing is a normalization of getting vaccinated. And so the questions in a lot of instances have gone from, are you going to get the vaccine, to, you know, when are you going to get the vaccine, or what kind of vaccine do you want to get, which is a little bit of a subtle difference. And we've seen overall that hesitancy has come down in a lot of communities of color that we've had a lot of these concerns about in the beginning. That still persistent high hesitancy group is still the rural aspect of our population that Dr. Avula mentioned. But we're seeing that using different approaches, forums like this, going into communities, pairing vaccination with access, because remember, you really can't separate the two. Our decision to engage in a resource is partly linked to our access. So if you have someone who is leaning towards getting it, but you have a long, complicated sign-up process, it's very difficult. They may not be able to get time off for work or not a lot of time at home before you have to go back. That person is going to be less likely to sign up than the person who has the very same sort of leaning, but the vaccine is available down the street, you know, a few blocks away. You know, we do the same thing. We're more likely to use coupons if they're in the grocery store rather than trying to search through pages of internet to track it down, even though we could all agree we want to save money. So we have to pair access with that, with the decision making to engage with the vaccine, which is exactly what Dr. Blue was talking about, that the two go together. But we have seen in general that the message has gotten through the community. There's always more work to do. There are always more discussions to have. And I think that now that we have many more people that have been vaccinated in communities, we have in our own way ambassadors who can talk about getting the vaccine, you know, the spiritual lift that so many people have described from getting the vaccine, and just knowing that you have that protection from, you know, no matter what's happened to you. COVID's taken a lot away from us, but once you've gotten that vaccine, and it's been 2 weeks, it's not going to take your life. That's a good feeling that people can talk about with their neighbors and their loved ones, and that's a very powerful effect.
Ron, are you in a position in the Blue Ridge Health District where you can give people a choice of vaccines, or do you just use whatever's available?
Well, initially we were sort of limited in what we could offer, depending on the allotment. So Moderna or Pfizer, and for us, Pfizer was really the one we were trying to administer here in Charlottesville, because the cold chain concerns and how different it was compared to Moderna out in the field. But now we're in a position where we are running very specific clinics for each of the vaccines. So whether that's Pfizer first or second dose, Moderna first or second dose, and now given the increase in Johnson & Johnson we've received, there are options where people can go in, look at the different clinics that are available, and then make the choice of whether it's Johnson & Johnson, Pfizer, or Moderna.
Speaking of Johnson & Johnson, Dr. Avula, you mentioned the importance of that shot for vaccinating college students, which is of course important in this community because we have a lot of them. Could you tell us a little more about that and what that looks like right now?
You mean what our plans are for being able to vaccinate college students? Yeah. I think there's a lot of college students across the state that we're all trying to figure out what's the right way to prioritize them, and there's a tension here because in some regards we've all through phase one have really prioritized individuals and their individual risk against COVID, right? We picked the 65 and up and folks with underlying conditions because we know that they're at highest risk to get hospitalized or to die of COVID. As we shift into phase two, we're really thinking more communally about herd immunity. And we recognize that while we're not as concerned about the consequences of COVID for college-age students, we are concerned about their contribution to community spread. And there's plenty of data to show that, young adults are drivers of community transmission. And so we're really, really trying to ensure that we can get to college students before they go home for the summer here. And it's going to be a little bit of a feat based on allocation, but we're really trying to map out every institute of higher ed in the state, public and private, to figure out based on their last day of classes, their graduation date, when we can potentially slot in those vaccination opportunities. I was feeling really good about our ability to get there last week, and then the news out of Baltimore, the Johnson & Johnson lab, where there was a mixing error, they had to throw away 15 million doses of Johnson & Johnson. So I'm hoping to get more news from the federal government tomorrow about what impact that actually has on our J&J allocations. This week, we have received or are in the process of receiving about 124,000 doses of J&J for our state allocation, and then almost another 100,000 doses through the retail pharmacy partnership. So that's a significant number of doses that they came in and really allowed us to be able to say, hey, April 18th with confidence, we can get everybody to phase two. Now, next week, if that 15 million dose loss actually impacts the weekly distribution, that may make it tough to get to all of those colleges at the right cadence. And so we've planned it all out. We know what dates that IHEs are ready to go. For almost all of our institutions, we know who's going to be doing the vaccinating. We just have this last piece of, are we going to get enough J&J next week and all of the weeks through April and the first week of May to actually make that happen? But know that it's absolutely our intent. We've got all the plans in place. We just need the doses, and then we can make sure that college students get vaccinated before they are released all over the state and all over the country.
Well, time flies when you're talking with really smart people. So we are almost near the end of our hour. Would love to give each of you an opportunity to just outline some of the highest level takeaways from your perch. Maybe Ryan, we can start with you. If you're talking to residents right here in the Blue Ridge Health District who are wondering how things are going, could you summarize any things you'd like to make sure they leave with?
So we've administered almost 99,000 first doses. And by we, I mean UVA Health, our providers, the federal pharmacy program providers, and certainly our health district. It's been about 3 months, and we feel like we're making really good progress. We know that there are a lot of people who are eager to get the vaccine. They're awaiting their emails and their opportunities to get an appointment. Patience is important as we continue to work through what we're trying to accomplish, and remembering that even with those numbers, we have a ways to go. We're working to increase our appointments on a daily basis. We're still building up that infrastructure, getting more vaccinators made available so that we can increase our ability to meet the demand. And then also, I think it's important to remember that we are continuing to work with our partners on a community and a neighborhood level to provide access to those who may not want to come to the larger sites, who are hesitant to get the vaccine. And I think having partners like UVA Health, the city of Charlottesville, Albemarle County, those that are really doing the on the ground grassroots work will continue to do that, even though we're bolstering up 2 large vaccination sites, one at Seminole Square where UVA Health is operating and where we are operating out of JCPenney.
And Dr. Bell, throughout the pandemic, you have been one of those critical partners here in our community with your hand in so many of the different efforts to make sure that we both educate and reach services to so many people. What would you like to leave people with tonight?
Well, the weather's changing, it's getting nicer outside. And I think along with that, just to reflect on the past several months, there have been a lot of dark times, but I see the light at the end of the tunnel. And I can see the way out of this. And it's really on the back of the vaccines, breaking the back of the pandemic. And the theme that I get when I speak with almost anyone about this, whether you've had COVID-19, a family member, or you're just concerned, or your child's not in school, COVID-19 has been so disempowering. That's like the thing that it's done to all of us. It has taken power away to have self-determination over what we want to do, when we want to do it, and how we want to do it. But getting the vaccine, that's really that first step towards taking some of that power back. And I'll tell you, when I started to see pictures and videos of grandparents going to hug their grandkids, and it's been over a year, and just the tears and the happiness that you see out of those moments, not only is that getting back to some semblance of normal the way, we were before this, it's hard to remember now, it's been so long, but that's an instance where you're getting some of that power back. And so despite all that's been taken from you, you protect yourself, you protect those around you, you get a little bit of that power back. And so I encourage you, if you have questions, if you have concerns, make sure you speak with someone that you trust, engage in forums like this. I do a lot of events like this as well. I'll be on Facebook starting in 9 minutes with Dr. Webb, and we'll be taking questions as well. We do this every Monday at 7 p.m. because it's that important. But make sure that you are well informed and you can make a decision to make that positive step towards taking some of that power back and keeping yourself healthy.
Well, thank you so much for all that you've done. And Dr. Avula, do you have parting thoughts for us too?
Sure. Maybe some words of reassurance for the folks who live in the Blue Ridge district. We've learned a lot about the distribution of vaccine, about where the demand is, where the uptake is, and there were some surprises along the way, Blue Ridge being one of those, just in terms of the degree of desire there is for the vaccine. And so as we shift into phase 2, we're really going to take a lot of that learning from phase 1. We're moving more to a demand-based distribution model from the get-go, starting April 18th, when we all move collectively into phase 2. And we'll monitor that uptake much more carefully week in, week out, to try to make sure that we all can kind of reach the finish line sometime in mid-May. And then my last kind of plea to all of you, I think that Dr. Bell outlined so many of the important reasons that we should get vaccinated, certainly for our individual health, for our community's health, but there's a lot of reasons that people don't want to. And sometimes it just takes, hearing from a trusted provider like Dr. Bell, or hearing from people in your community that you love and care for, to say, hey, this is important to me. Would you consider doing this? And so I'd ask all of you just to think about, who are your spheres of influence? What are your opportunities to encourage your friends, neighbors, colleagues, loved ones to really consider taking that step towards vaccination? And Delegate Hudson, to you and Senator Deeds, thank you so much for just creating platforms like this, because I think it's conversation, it's talking about things like safety and hesitance in a non-judgmental forum that really allows people to get their arms around this and hopefully make a decision to get vaccinated. So really appreciate the time.
Well, thank you for all that you're doing in a shifting landscape constantly. Senator Deeds, you want to close us out?
Thank you very much. Thanks to you, Delegate Hudson, for putting this together. Thank you all for participating. Ron, Dr. Bell, Dr. Avula. It's important that we get as many people as possible vaccinated so we can get to that point where we can get to the light at the end of the tunnel. And I'm so glad to hear. I'm optimistic after this talk. Thank you.
Well, thank you all for all that you're doing. Thank you, especially Ryan, for everything that you've been doing to make sure we get those shots out to our community here in the Blue Ridge. This video will be posted online on YouTube and Facebook. If you're watching now and heard anything that you'd like to share with others, I'll be sure to send out an email afterward with some of the top line points for some of these great questions. And thank you all around to all of you for sharing your evening with us. We so appreciate all of your work. Have a good night.